Good evening everyone, how are you? Hope you are doing good. Today I want to discuss about one of the important topic, that is GLP-1 physiology. Let's go into the topic. So they are incretins, they are G hormones that are released after the meals and they stimulate the insulin secretion. The currently established incretins are GLP-1 and GIP. GLP-1 is glucagon-like peptide 1 and GIP is gastric inhibitory polypeptide. So where they act through the specific receptors on the beta cells of the pancreas to stimulate the insulin secretion. The GLP-1 receptor has become an effective drug target with the numerous glucose-lowering drugs have been developed that work through this mechanism. This GLP-1 receptor is also expressed in the brain, and the GLP-1 receptor agonists, they activate these receptors to reduce the food intake, they decrease the appetite, and they possibly augment the glucose-lowering actions that occur through the enhanced beta cell function. Efforts to incorporate the GIP receptors also into the diabetes therapeutics, they are under development. So both GLP-1 and glucagon, they are derived from the precursor called pre-pro-glucagon, which is a 180 amino acid precursor with 5 separately processed domains. So they are amino terminal signal peptide, which is followed by GLPP, that is glycantin related pancreatic peptide, glucagon, GLP-1 and GLP-2. And processing of these proteins is sequential and occurs in a tissue specific fashion. So pancreatic alpha cells, they cleave the proglucagon primarily into glucagon and a large C-terminal peptide that includes both of the GLPs. Intestinal L cells and hindbrain neurons, they process proglucagon mostly into a large N-terminal peptide that includes glucagon and a GLP-1 and GLP-2. GLP-2 affects the proliferation of the epithelial cells lining the GI tract. So we have one drug called teduglutide, which is a GLP-2 analog, is approved for the treatment of short bowel syndrome. Let's talk about the processing of proglucagon to glucagon, GLP-1, GLP-2 and GRPP, glycantin related pancreatic polypeptide. So where they are happening in the isolated alpha cells, intestinal enteroendocrine cells, that is L cells, and a subset of neurons in the hindbrain. So where in these tissues the proglucagon is synthesized. So in alpha cells, the prohormone processing is primarily done by the enzyme called proconvertase 2, which releases the glucagon, GRPP and a major proglucagon fragment containing the 2 GLPs. In the L cells and neurons, the proglucagon cleavage is mostly done by proconvertase 1 or 3. They yield glycantin, oxyntomodulin, GLP-1 and GLP-2. So let's see the picture. The proglucagon, which contains 5 domains, GRPP, glucagon, GLP-1, GLP-2, they are connected by IP1 and IP2. IP1 is connecting glucagon and GLP-1 and IP2 is connecting GLP-1 and GLP-2. So in pancreatic isolated alpha cells, where the proconvertase 2 is dominant, they cleave the IP1. So what they yield? GRPP, glucagon and GLP-1, IP2, GLP-2 fragments. This is called major proglucagon fragment, which contains GLP-1 and GLP-2 connected by the intervening peptide 2. So in the intestinal L cells and the solitary tract nucleus, where the proconvertase 1 or 3 is dominant, they cleave the IP2 from the proglucagon. So what they yield? They yield GRPP, glucagon, IP1 complex, that is called glycantin, and we have GLP-1 and GLP-2. And this complex is further cleaved to GRPP and glucagon IP1 complex. That this glucagon IP1 complex is called oxyntomodulin. So when GLP-1 given intravenously to the diabetes subjects in supraphysiological amounts, they stimulate the insulin secretion, inhibits the glucagon release, delays the gastric emptying, so they reduce the food intake, they decrease the appetite. They normalizes the fasting and postprandial insulin secretion. This insulinotropic effect of GLP-1 is glucose dependent. So when there is increase in glucose, there will be more increase in insulin release. So in that, the insulin secretion at fasting glucose concentration, even with the high levels of circulating GLP-1, is minimal. So negative GLP-1 is rapidly inactivated by the enzyme called DPP4, that is called dipeptidyl peptidase 4. So they yield the plasma half-life of GLP-1 about 1 to 2 minutes. So the half-life of negative GLP-1 is very low, 1 to 2 minutes. So the endogenous peptide of GLP-1 is not a useful therapeutic agent because of its short half-life. So they have made 2 broad strategies that have been taken to apply GLP-1 to therapeutics. So what are they? The development of injectable DPP4 resistant peptide agonist of GLP-1 receptor agonist. So long-acting GLP-1 agonist, we have liraglutide, and the creation of small molecule inhibitors of DPP4. So by inhibiting the DPP4, they will increase the concentration of GLP-1. So these are the major 2 strategies. Thank you so much for your kind attention and kindly share my lectures to your friends.